Welcome to the 10th webinar in the MGHS Institute Interprofessional Webinar Series. My name is Pauline Lesage. I am a physician educator at the MGHS Institute for Innovation in Palliative Care. Today, we are going to talk about consent to care. And I'm very glad that we do so. This is my favorite topic of all times. And I will be able to use some of my legal background maybe to sort out the concept of consent. I will present two parts of this consent. First will be the general concepts related to consent, and the second part will be addressing ideas related to the patient's lacking capacity. So just to make sure that we are all on the same page, consent, even though this is something that we do regularly, that we do every day at various levels in the medical field, but also in other fields like buying a car, like doing anything, there's a lot of requirements in the law, and it's a highly legal principle. Therefore, we will have to go through various elements that we will describe here during this course that are really not to our liking, maybe necessarily so, but are really part of consent. Therefore, a real consent, and really an objective consent, it is one of the most difficult things to get really well done. And this is why we are going to illustrate that today. And hopefully at the end of this lecture, we'll be a little bit more familiar about the requirements of consent. So, general concepts. Which one of the general concepts that is the most important thing is that, and this is the second part, I'm sorry to illustrate here the slides for the second part, the lack of capacity of patient. So consent is not in a neutral setting. Consent is part of communication. There's two people involved in consent, one that gives the information, the other one that receives it, and then a discussion, and then finally we agree on something. So as you can see, who says communication, says limit to communication. And this is why I think this concept is so difficult, because everybody who is taking part of obtaining a consent do have some barriers, some limitation. Physician as well, or nurse I can say, or any professional who is getting a consent, a social worker or any other part of the team, the patient on the other side, and also a third party oftentimes that we have to deal with, family, friend, or somebody else. On the physician point of view, the barriers that we identified, there are many others, but just the most important maybe, the technical language. As you know, we are all familiar talking in a certain way, and for us certain terms are really simple and we tend to use them. So oftentimes it may not be understood nicely by the patient, who eventually may not even ask questions, not knowing what we are talking about. So there's a kind of something there with the language, and we all have experienced that in the past. There's a lot of medical uncertainty. The task is to ask patients to give us a consent for us to do a procedure or a test, a treatment, and so on and so forth. And at the same time, it's not 100% sure what we are presenting. The information that we are giving to the patient, it's not black and white, it's oftentimes in the gray. And so the more experience a physician or a nurse or a social worker have in obtaining a consent will present the facts probably differently. We know more, therefore we'll present differently. So, and also the uncertainty, we cannot tell the patient 100% what it is, therefore it will create some question in the back of the mind, and when the patient will give a consent, it may be difficult to deal with that part. Consent not to alarm the patient. We all saw in the first lecture about prognostication that we tend to be, in the medical field, we tend to be very optimistic, and so we don't want to alarm the patient, so we present oftentimes the facts a little bit better than they may be in reality. Time frame, we are all limited by the time. Therefore, sometimes we will cut short. We'll give less explanation, more explanation, depending in the time frame that we do have at our disposition. as persons in the medical setting, we all have denial and personal factors. We all, especially when we discuss end-of-life advanced disease, we all have our own ideas about how things should be, and therefore perhaps we tweak a little bit the information when we talk to patients or family. There's also the liability question, which is a very part of consent, of course, at every turn. Patient has his own limitation. Understanding, it's not everyone who is understanding. The level of education is different from one patient to the other. They can be also inattentive. I say something, but then, oh, I'm losing, after a few sentences, patient is not thinking right, and you will make a decision on what I'm saying. Fear and anxiety, obviously, when you go to have some news or to decide on treatment to your healthcare professional, well, there's already a little bit of angst in the back of that. What is he going to say, and so on and so forth. That will also cloud maybe our sensorium to receive the information properly. The effect of the illness, medication, all that also will influence and will create some barriers. The denial, the trust, just the trust that we have in the clinician who is talking to us will make a big difference. We trust this patient, this attending will see things differently maybe than if we come and in this conversation without good trust. The third party, the barriers sometimes that can really be helpful or not, will be the third party or the family, either when we will talk about patients with lacking capacity and they will help us to make the consent, or simply when they are accompanying the patient and are there to help us to sort out and get a better consent. So they are also have their own guilt, denial, trust, or loss. A lot of third parties sometimes will influence the patient to take that or that decision because they are so afraid. Let's give an example of withholding withdrawal of treatment. And sometimes some family member will say, well, we cannot hold that, and will influence the patient to go that direction because they are so afraid to lose the patient for various reasons, good and bad in time. So decision-making model is not in the emptiness. So it is part of communication, subject to barriers of communication. It is also what we call part of the decision-making model. And there's about 3 models we are going to see here briefly, a few that you know already. Probably some of you know the paternalistic model, which is almost gone from our medical field since the informed consent has been developed in the 80s and 90s. So the time when a physician was discussing and taking decision and was just informing the patient are almost gone, and very few will see this pattern. We have also what we call the informed choice model, which is a little bit what we tend to do at the beginning of this informed consent when it was starting in the 80s. We said, well, okay, now the patient is deciding on the principle of autonomy, that's fine. Therefore, I'm going to give him all kind of information and then he'll choose. Like we were throwing at patient all kind of information and leave it there, and then that's his choice. I don't think that the doctrine of informed consent was never made to do such a thing, because it seems to me almost impossible for a patient in the medical field who come to you to seek advice, to have some information to make a decision, should just be thrown all kind of facts and then decide. So then we developed the third model, which is probably the best one, what we call the shared decision making. So in this case, the ethical principle will be again respect of autonomy, but also of beneficence. It will be a relationship centered. The information will come from the medical or from the medical staff, but also will include and will take into consideration some personal values of the patient. And the decision making will be bilateral. It will be it will not be the physician per se alone, neither the patient, but in sort of communication to understand what's really is at stake. So you can understand already how difficult this will be in the practical daily life. So consent to care, the legal ground, it's clear and simple. It's on the principle of autodetermination, and the ethical ground is based on the principle of autonomy. So this is what motivates all this informed consent and why we have to get an informed consent. Now let's get into the different part of a consent. And oftentimes we get carried away by the second part, by the authorization, by the sign form. We have a sense that all patients sign here or in any type of consent. I sign there, therefore that's a done deal. Well, as you know, the authorization of consent, the sign form, is just one part of it. We'll come back to that in a minute. But just to say that that's not the only part, and it can always be invalidated. It's not because you sign something that the consent is sealed. You need, first of all, to have received the information. And then again, the information, and then I'm going back to a little bit the legal background here. The legal information contains elements that you have to say, you have to talk about. It's not just a conversation for the sake of conversation and a broad explanation. All those elements that you do see on this current slide are essential to get a real objective consent to respond to the legal requirements. First, we have to talk about the nature of the illness, what's going on with you, what I found, and so on and so forth. I'm putting that in the context of the illness, but a social worker will get a consent, will put that maybe in a different concept. But these are the requirements that need to be said. What is the nature of what we are discussing? The nature of the procedure of the treatment. So and so you have COPD. I'm preparing to maybe we should start the oxygen, so on and so forth, and then what it does entail. Then the risk that this procedure will sort of give or bring with it, the probable, the foreseeable risk. We'll have another slide on risk because the risk issue is somewhat very difficult because there's various literature on that, and what kind of risk shall we say is not always clear. The result anticipated, if I'm proposing a treatment, proposing a procedure, I'm expecting to have some results. If you are planning to withhold or withdraw a ventilator, you have to explain what will happen to the patient at that point. The possible choices, and again, and the risk and benefits of each choice. This is something that we oftentimes forego. We are so convinced that, going to that procedure is the best to do, and then we do the whole preparation, the pros and cons, but we don't present other choices. And as you know, there's always other choices, including do nothing. Don't do that surgery, don't go on this vent, don't go to this chemotherapy, and so on and so forth. So this has to be also presented. The consequences of a refusal. As you know, the refusal is exactly the same principal requirements as the consent. Patient can refuse when he has capacity, almost anything under the sun, as long as he has been informed and understand the consequences of a refusal. An answer to question. There's no full obtaining consent without answering the question. If patient doesn't have, maybe yourself ask question and make sure that the patient didn't understand. The risk, I will pass by here a little bit faster. We can spend some time over there. This is always something that physicians struggle with, because what kind of risk? We are not there to speak about all the risk possible to a patient, otherwise it will take a terrible time, and finally nobody will make any decision because there's too many things that can happen. You just have to observe those commercials on television about any medication, and at the end you say, well, who wants to take that medication? You can die, you can do this, you can bleed, and so on and so forth. So again, there's requirement though, and risk needs to be told, but they may be variable according to what setting you are in. For sure, if a patient is serious for a patient, if a risk, sorry, is serious for a patient, example, you have a patient who is going to for some treatment, but he's already having cardiac disease, COPD. Of course, it's much more a risk to have an arrhythmia or to have even a cardiac arrest. So we should know about that going to this procedure or this surgery will be worse for him than an ordinary person. There's also significant risk, and the most important, of course, needs to be told to the patient. Increase when a choice is possible. If you offer a choice to a patient and one procedure is much less dangerous or much less risky than another procedure, patients should know about that. And of course, if you are in the research field, there's absolutely no place for avoiding to tell any risk. All the risk needs to be told, no matter small, big, important or not, that they should be. Again, the importance of that, what I'm saying is that if you miss one part of that, you don't say the risk, or you don't take into consideration what kind of procedure and all that, you can invalidate the treatment, because all those elements, you can invalidate the consent. All those elements are essential, are requirements to get an objective consent. Now, the quality of the information that you are giving to a patient should be objective, and then already we are hitting a hurdle, because objective, yes, how objective? None of us is really 100% objective. We are not machine, we are not, you know, we know things, but we are a bit influenced, biased by what we said initially on one of the first slides. So, but the objectivity is essential, and not what you think that should happen to the patient, not what you think the patient should decide. And we tend to tint it a little bit. As you know, there's a big difference between presenting to a patient the facts and putting the glass half empty and half full. If I start digging into all the nice things and that, just at the end, in the 2 minutes, I just say, oh, you know, by the way, there is this and that, well, already the mind is already set. So you see that the objectivity can be questioned oftentimes. It should be concise. There is no way, and for time's sake, that we can spend hours and hours to get a consent. We cannot go through the day for that. So this is why we need really to target the important thing and be very organized when we go to talk to a family or to a patient for obtaining a consent. It should be understandable. It makes sense. How oftentimes, though, we don't do that well. We have, especially in New York, we have many patients that speak different languages, and sometimes we don't take the time to have an interpreter or use the line for an interpreter, and then always say, well, sign here, okay, I'll discuss that. I use my broken Spanish or my broken Russian to get that consent, and I wonder how good we are at times and how understandable it was to the patient what we said. And the criteria for obtaining a consent is the reasonable person. It's not talking to a physician already knows thing. It is a reasonable person, what an ordinary person would like to know in such and such circumstances. Two little things here I will pass fast because of sake time. Fear of knowing and therapeutic privilege can be acceptable at times, but under multiple conditions. So I don't have time to go much into that, but be very careful in using that and make sure that you document, and you will have to prove that there was a good reason to do so. Consent to care, there's exception, and as you know, emergency. If you cannot get a consent in the emergency and you will perform something that will be salvatory for a patient, for a family, I think you can go ahead and discuss afterwards. So emergency can be if you cannot obtain, and it's not a free-for-all and then because we are emergency, let's go for it. That's not what it meant if you cannot get it. Exception also stipulated by the law, as you know. Now, the consent form, great, and we feel so secure when somebody just write their name there and sign the form. But Again, as I mentioned before, it's an element of proof. It's not a whole proof of valid consent. It's an added element. It's not a replacement. If you did not provide the information, even though the patient signed that, I can invalidate the consent at any time. So again, be aware of that. Right to refuse. Patients can refuse any treatment. Again, the requirement is as the same as a consent. Patient needs to know exactly what he is refusing and the consequences. Now let's go into the patients who lack capacity. And this is something that we are going to see oftentimes because of the aging population, because of the dementia that is growing, and so we need to be prepared for that. And again, there's a lot of legality into this. We cannot talk to anybody, special people we should get the consent from, as you already know. There's also, I should mention, maybe I did not say, that in terms of consent in patients with lack of capacity, there is a lot of requirements from different states. So you need to be aware of the legal status of certain things, or the Living Wills example, in your own state. If patient is declared lacking capacity, it is a terrible thing to be declared lacking capacity. That is to say, you cannot make decisions. You are lacking, you are losing your autonomy, and then somebody else is going to make decisions for you. So it's a very profound, important denial of a right to a patient. Therefore, it should be done properly. Usually, the attending physician, confirmed by another MD, in writing will be the best way to really acknowledge that the patient is lacking capacity. There's no necessity to have psychiatric evaluation, although it seems that it seems to be the way in the hospital where we tend to ask psych evaluation, except especially when I think we are dealing with something that's extremely important. Will have a lot of consequences, life and death decision, and if it is a little bit complicated, I think the help of psych evaluation will be good to have. There's no legal standard criteria for evaluation of lack capacity, surprisingly enough. This is why perhaps we use psychiatric evaluation. So suffice to say that we can probably use some of those easy mental assessment, but probably the best way to see if patients lack capacity in a certain field in the consent that I'm trying to get will be to ask the patient to repeat what we did discuss and talk about. So that will be the best, probably convincing evidence to say that the patient did not understand. I'm just opening and close parentheses here. You know that lack capacity, patient can lack capacity overall in general for nothing. They cannot absolutely not make any decision. But sometimes the lack of capacity can be just for certain decisions. So every consent needs to be addressed. That patient may not be able to make a big decision on end-of-life care, but may be able to make a decision about if he wants that procedure or not. So you have to be very careful not to consider that a consent needs to be set in a particular setting. Advanced background, legal, I'm just passing again here a little bit on the fast mode, just for you to know that this is set in a lot of our laws. Some are federal, some are more state. And in New York, we have the latest born was in 2010, the New York Family Health Care Decision Act, who really determine who is the surrogate and who can make decision for the patients lacking capacity. So again, the legal background, and this is there something, it's all over the board, it's everywhere in all states, that facilities, whatever facilities that is, including of course some MGHS and all of that, needs to be in compliance with state law governing the advanced directives, and of course know about advanced directive and decision making in advanced disease. So what will happen if patient lack capacity? So a few things can happen. We can have advanced directive modalities, and they are twofold. One is that patient took the time to mention or to name somebody that we call an agent by a form that we call healthcare proxy. Healthcare proxy is not a person, it's a form that determines somebody can make decision in the case that you become incapacitated. Coupled with also what we call the instructional directives. Anybody can write on a piece of paper, I will see the requirements later on, that for in such and such situation, I don't want that to be done and so on. So just give, instead of calling that a will, which has to do with your assets usually, but just a living will about what to do with your body in such and such circumstances. And there's also the NOLS form. So for each of one, we'll just discuss briefly, because again, this is something that we can go on and on with particularities, with cases. It is unfortunate that we don't have the time to have specific and difficult cases. That can be, something we can recommend to have another webinar on. So the healthcare proxy, and it's a document, it's not a person, it's a document that designates someone to be an agent. So the person is the agent with authority to make decisions, usually, ideally, supposed to represent the preferences of the patient, but if preferences are not known, according to the best interest of the patient. So you can understand, and this is also a mistake that we see all the time, only a person with capacity can do that. And because sometimes we see, well, maybe we can ask my mother if she wants to name me or this one and this one. Well, patients lack capacity. She cannot do that. It's too late for that. So only a patient with capacity can name an agent. If patient determine what you do have, what the preferences they would like. So you are just fulfilling when you will make decision for this patient, the substituted judgment, what the patient would have liked to do in this case. If you don't know the preferences of the patient, he named you, but unfortunately did not have time to discuss too long, then the agent will need to make a decision according to the best interest of the patient, which is the balance between benefits and burdens. So we put that in the balance, and then we'll try his best to make a decision in the case where there's no preferences. So who is the person who makes decision when a patient lacks capacity? First, it will be the healthcare agent, which is through the proxy form. If none of that exists, then it will go to the surrogate. And the surrogate in the state of New York may be somewhat different in some other state. This is why I think we need to look into that. Will be the guardian. If there's no guardian, the spouse, then the son, the daughter, then the parents, brother, sister, and close friend. And this is hierarchy. Even though there's a friend and there's a spouse, and oftentimes you will see that there's a lot of not going well together, and sometimes, of course, the close friend may know more than the spouse, but nevertheless, according to the law, the spouse will prevail on the close friend to make the decision. Proxy designation, it's an extreme important role. You just designate somebody to make decision for you, so you better know who's that person and tell her and the most you can. Unfortunately, we pick up always, spouse, thing like that. Don't think that they know the best from you. If you don't talk to them, they may not represent. There have been studies showing that those friends, family have difficulty to let go, and their mentation may be clouded by that fact, and they have a hard time to make decision. So I think the best way to have a good proxy is to tell them what is it really that you want through a living will. A physician can be an agent, but should not be the attending physician. So the requirement for proxy, please, if you fill a proxy form, make sure that requirements are there. Too oftentimes we have to invalidate a proxy form because there's one requirement missing. And if one is missing, that's it. The document is no good. So name of the patient, statement of what person will replace that patient must be signed and dated by the patient. That's sometimes not there. Must be signed and dated by 2 witnesses. And alternate agent can be designated. If we want to have 2 agents, can do. So, and statement as patient wishes regarding artificial hydration, you may want to add that, not necessary. Suffice to say that my agent knows my wishes on artificial hydration and nutrition. As you know, artificial hydration and nutrition is always the most difficult decision to make and to withhold or withdraw. So this is a form of healthcare proxy. You just have to put healthcare proxy on the web, look on the internet, and the form will appear. It's probably across the board, as they are all similar, and this is a valid form. So easy to fill up, but please fill up all the requirements, otherwise it would not be valid. Let's talk about living wills. Living wills are instructions made by an adult, orally or in writing, it's preferable in writing, related to medical decisions in the event that decision capacity is lost. So again, this supports the principle of autonomy. I cannot decide for myself, therefore I'm writing to what I would like, my preferences in such and such a case. It can be oral or written, as we said. Written is probably better, it's more better proof than oral. There's no statute governing the living wills. You can make all kinds of living wills. We'll show you a form, but then there's multiple ways of doing that. But according to the Supreme Court, if somebody comes and showed a living will done previously by a patient, it will constitute clear and convincing evidence, and we cannot discard that and say, well, it never existed. If it is well done in due form, then it is a valid document. Just a little bit of history here. It was introduced in '68. But surprisingly enough, even though it's on the market for a long period of time, completion by only 25%. And I was reading that again in the New York Times. There was something written over the weekend, and not many people, just 1/4 of the population. Why? Multiple reasons. Some people don't know about that, reluctant to discuss it. Some people have a sense that if they discuss what they would like to be, it will happen, or they will die next day. A bit like a will. When we do a will, well, we wait till last moment. No, I think the sooner the better, because you never know when an accident or when something will happen, and you will need that. If it's not done, it cannot be done in the last moment when you lack capacity, obviously. So the terminology, there's a lot of things that have been involved. It is unclear what is really the real reason for that. But I think that every one of us should think about doing such a thing and talk to people about that. So this is a New York living will, but it will be probably more or less the same in any other state. Again, you just go on the net and you just put living will, and there will be a lot of forms that come. Easy to do. You just need 2 witnesses and your own. You can add to that, and some people will have a living will of 5 pages, but you don't need to. You can be very specific. Don't forget that those living will need some interpretation. So the more specific you are, it may be harder. So sometimes it's better to give a leeway so it's open for discussion. Otherwise, then you close the door, and then if it's not the exact wording, the interpretation may be more difficult. The MOLS is another type of document that can be done either with the patient, who can be discussed with also with the surrogate about what patient would like to be done. So it includes much more than just the DNR. It includes antibiotics, IV fluid, feeding tubes, and so on and so forth. There's multiple parts to that document, so it's 4 pages document. It's mainly used in the nursing home. So this is the document. Again, I'm sure you can find that on the web. And so multiple part needs to be signed by a physician and by the patient or / the surrogate who represent the patient. Now, in conclusion, even though you remember just those little things, I think it will be extremely important, and I will have achieved my goal. consent is embedded in communication, and then it's subject to barriers. And therefore, there is no probably such a thing as a pure objective consent. It is the most difficult thing to get and to succeed into. When patient lacks capacity, the rule of obtaining consent still apply through advanced directive. And everything that I said in the first part, talking to the patient with capacity, will remain the same when patient lack capacity. I will have to inform, obviously, the decision maker with the same rules. Consent does entail, specific legal rules. And this is not to our liking. It is there to stay, and the elements that I try to present today are really necessary to get an objective consent. One thing here that I did not mention, but clinicians, whether they are, must be comfortable that the agent or the surrogate who represent the patients act in the best interest. If there's a question about that, you can always say, I'm sorry, I cannot respect what you are doing. And as you know, we have all kind of people who represent patients, and sometimes with good intention and sometimes not with so good intentions. And it did happen in the past that we have questions about the role of the surrogate, that what he was requesting was not really in the best interest of the patient. So you have to stand up to that, and there are administrative as well as ethics committee to deal with that and help us to sort this out. Last one thing about consent and those living wills and things like that. They do not apply, the living wills do not apply to acute, potentially reversible situation. And then again, we had multiple, sometimes divergence with family and said, well, he signed this living will, never wanted to be on a vent, therefore I don't agree with this vent, we need to withdraw. Well, wait a minute. This patient, as example, let's say elderly patient who come with pneumonia, but he happened to have COPD, and he is more fragile, more respond differently to the pneumonia because of this underlying COPD, and then he needs a little bit help to breathe, but that will be in the reversible context. It's an acute pneumonia that I can reverse a day or two on a ventilator, and he will get back to baseline most likely. So I think we have to be very careful because the application of those living wills are usually in irreversible condition, especially when it is time to withhold or withdraw treatment. I will stop here. I'm sure there may be some question on consent. I wish we had a little bit more time, but maybe in another session. So I'm looking here to some of the questions here. My understanding is lack of effort can be compared by a nurse practitioner. I think who can do the lack of capacity? It's a good question. Is a nurse practitioner can do that? I think you have to make sure that, and the law is changing. As you can see, consent is very legally based, and all those laws are changing with time. So you need to make sure that in your surrounding you can do that. A nurse practitioner can do this and that and not that. So again, I don't want to answer precisely to that question. You just need to confirm with your own a professional body. Who defines what medical decision making can be done by a court-appointed guardian? Well, there's no such a thing. If a patient has nobody to decide for himself, there is no family member, and it can be sometimes a very long inquiry. We used to have a social worker in our place where I was working before. We call her the detective, because we have those patients who come in the medical ICU example who are placed on a vent, and we need to see if we should, the DNR is in discussion, of course, should we stop treatment, shall we limit the treatment to this and that, and sometimes there were nobody to answer to those patients. There's absolutely, there was no family, but by the way, by the time it takes to discover that, maybe many days. So if there's an emergency, there's a rule. We can always do an administrative consent, so that does not need to have somebody. If it's something that's very urgent, patient is bleeding, we need to transfuse the patient, it will be a good measure, so we'll go for it, not waiting. If this is something that can be waited and it's not some immediate action that needs to be taken, we may want to go to and try to name a guardian. Guardianship process is a long process, and so it can be very difficult, very cumbersome also, and that will be the case. A guardian will take over and a guardian will make decision will be only in the case where there was a guardian. And a guardian is a legal process. As you know, you need to go to court, you need to have a form of paper deciding that this guardian will decide. And then again, the guardianship can be for this and that, for various things. It's usually stipulated into the guardianship process. So this is something. I think that what we can recommend, and this is something that we see with our patients, and if I can open and close parentheses here, encourage all the patients, because we have many, especially here in New York, patients who live alone, you have nobody to make decision in case things will happen to them. We should encourage them to have at least the name of a friend, the name of somebody, because otherwise it really complicates tremendously the decision-making in advance disease. And I must say that I've seen patients that we pushed the limits. We did everything to those patients because there was nobody to answer for them, and we were afraid to cut short. So then, of course, when there's absolutely nobody, there's no guardianship, and we are not going to wait months to maybe take a patient from a ventilator or discontinue that, there's always the administrative and ethics committee. So those cases, those difficult cases, will need to be presented to the ethics committee for resolution. If everyone, let me take that, if everyone feels hospice is in the patient's best interest, can we admit? I think it's too broad of a statement to say yes, there's a lot of things that in the best interest of the patient, but if the patient has capacity and doesn't want hospice, even though if it's in best interest, and as you know, a lot of patients do things that are not in the best interest. A lot of patients make decisions that are not in the best interest. If they have capacity, they can do that. So nothing you can do. If patient is not having capacity and some surrogate will make decision for them, we can influence them presenting the pros and cons, but it will be up to us to have a good conversation to present that. And you can still have a refuse, and unless it is a bad decision, and unless you prove that the patient is not receiving good care by not being on hospice, I think it will be very difficult to enforce that and say we should go with hospice. Hospice, I'm really pro-hospice. It's a good way, it's a good service, an excellent service, but it's not everybody wants that. There are many ways also to achieve the same goal, end of life, and so we should be open to that. If you feel that the patient is abandoned, not receiving proper care, then the recourse is to certainly refer these patients to agencies that deal with that, like adult protection or things like that. But again, you need to be open-minded, and this is what I'm trying to say, because we tend to have a narrow mind, a focus. Every one of us, if I was to ask you, this is this way we should die with this, that, with hospice. Well, be careful. There are many ways of thinking, many good ways to do the same thing as well, to achieve the same goal. And so be open, because when you are going to present the consent and the facts to the patient, you won't be necessarily objective. I'm afraid I have to stop here at this point, even though I'd like to continue for much more time. Let me remind you that the next webinar will be on February the 26th, and it will be by Dr. Ebtissam Ahmed, and she will discuss the opioid therapy in the medically ill, the side effect management. Please do not forget to fulfill your evaluation, and tune in 2 weeks for this great presentation. Thank you.